Imagine waking up and just the simple weight of your bed sheets resting on your legs feels like being burned with a blowtorch.
Which is just a terrifying thought.
It really is.
Yeah.
So you rush to the hospital terrified. You wait hours in the emergency room. They finally run an MRI, and then they look you dead in the eye and say, "Congratulations, your scan is perfect. You're fine."
Right, but you're definitely not fine.
You are in absolute debilitating agony. So today, we're taking a deep dive into the roughly 20% of the global population who are trapped in what we're calling the dead end of modern medicine.
And that dead end is, well, it's a massive systemic illusion. I mean, we are really decoding a healthcare framework that is brilliant at keeping us alive in emergencies.
Right, like car crashes.
Exactly. But it spectacularly fails at managing complex, invisible suffering. And our stack of source materials today is incredibly dense.
Yeah, we've got a lot to get through.
We do. We're analyzing comprehensive medical guidelines, European consensus papers on pain management, contemporary neuroscience literature, and this absolute behemoth of an umbrella psychiatric review.
That one looked at, what, over 17 million individuals?
Over 17 million, yeah. It's massive.
So the mission for this deep dive is to understand the actual biology of why normal test results often hide catastrophic dysfunctions.
And we're going to unpack how the medical system's hyper-specialized silo effect, just bounces patients around like pinballs.
Which is so frustrating for them. And most importantly,
Right.
we want to dismantle that terrifying medical verdict of there is nothing more we can do and totally reframe it.
Absolutely. But to start, we really have to look at the fundamental reason our hospitals are built the way they are.
Right. The triage mandate.
Exactly. They're built to fight fires. The entire foundation of modern medicine is rooted in evolutionary biology and acute survival.
So according to the guidelines we reviewed, acute pain is defined as pain lasting less than 1 month. Right.
Yeah, less than a month. It's a direct, proportional physiological response to a noxious stimulus.
Like touching a hot stove.
Right. You touch a stove, your skin burns, and nociceptors fire a signal straight up your spinal cord to your brain.
Which is, that's a good thing.
It's vital. It serves an immediate survival function. It forces you to pull your hand away, and it forces you to protect the injured tissue while it actually heals.
I always picture acute pain like a massive, just obnoxious fire alarm in a kitchen.
That's a great way to look at it.
You need it to be incredibly loud because you need to know the kitchen is burning before the whole house goes up in flames.
Yep.
And the medical system is essentially a fire department.
Yes. A doctor's primary drilled-in instinct is to locate the fire and extinguish it. They're trained to look for, severe ischemic vascular disease, advanced neuropathy.
A shattered femur or a tumor pressing on a spinal cord.
Exactly. But the complication arises when the fire is successfully put out, the tissue heals, but the alarm itself simply never stops ringing.
It's just glitching and screaming 24/7.
Right. And the sources define that as chronic pain. Pain that persists or recurs for more than 3 months, extending far past the time of normal tissue healing.
That at that stage, it's no longer helpful.
Not at all. The medical literature describes it as a biological paradox. The pain persists with absolutely no apparent evolutionary benefit to the individual.
It's totally useless suffering.
Completely. In this state, the pain has ceased to be a symptom of an underlying tissue problem. The pain has actually metastasized into the disease itself.
Let's introduce a hypothetical patient to ground this a bit. Let's call him Mark.
Okay, Mark.
So Mark strains his lower back lifting a heavy box. Acute pain. He goes to his GP. The GP follows the triage mandate, running x-rays or maybe an MRI to exclude those life-threatening fires.
Right, checking for spinal fractures or cancer.
Exactly. And when they don't find any, the GP tells Mark to take some painkillers, rest in bed, and avoid lifting things until it feels better. Which, for an acute injury, is pretty standard advice.
It is, but applied to a chronic condition, that exact same advice becomes highly maladaptive.
Really? Just resting?
Yeah. The research explicitly highlights the danger of applying acute pain strategies to chronic pain realities. If Mark's pain transitions into a chronic state and he continues to follow that strategy of prolonged rest and, fear avoidance behavior.
Like being too scared to move in case it hurts.
Exactly. His body begins this terrible downward spiral. Physical inactivity leads to severe muscle atrophy. The stabilizing muscles in his back weaken.
Which I'm guessing puts more mechanical stress on his spine?
Precisely, which generates more nociceptive input, which then creates more pain. His physical deconditioning actively exacerbates his disability.
So what was supposed to heal him in the short term actively harms him in the long term.
Yes. And Mark is stuck because his doctor only knows how to search for fires. When the doctor cannot find one, they just hit a wall.
And this is the genesis of the myth of the dead end.
Right. The physician assumes that if they cannot see a mechanical cause on a structural scan, well, there's no biological basis for the agony.
And therefore, no medical intervention to offer.
Exactly. But to understand why Mark's structural scans come back normal, we really have to dive into the invisible landscape of the nervous system.
Because it's not always about structural damage. The sources categorize pain into 3 distinct buckets.
They do. The first is nociceptive pain. This is your standard tissue damage. Osteoarthritis, grinding down a knee joint, degenerative disc, torn ligament.
Stuff we usually think of.
Right. Patients typically describe this as throbbing, aching, or a deep pressure. And because there is physical, structural wear and tear, this is the pain an X-ray or MRI is actually designed to spot.
Okay, and the second bucket is neuropathic pain.
Yes, which is a disease or injury directly affecting the nervous system's hardware.
Think of like diabetic neuropathy, where high blood sugar damages the peripheral nerves, or a pinched nerve from a herniated disc.
Or the aftermath of a shingles infection, yeah. Patients describe this as lancinating, shooting, or feeling like electrical shocks.
And scans or nerve conduction studies can often pinpoint those physical nerve lesions.
Usually, yes. But the third category is the one that really shatters the triage model entirely.
Nociplastic pain.
Nociplastic pain. Historically, the medical community called this functional pain, or sometimes psychosomatic pain.
Which carried a terrible stigma, like it was all in their heads.
Horrible stigma. The modern definition, though, refers to maladaptive changes that alter nociceptive processing and modulation. Crucially, without any objective evidence of tissue damage or physical nerve lesions.
So the hardware is structurally intact, but the software processing the sensory input has just become corrupted.
That's a perfect way to describe it. Patients usually describe nociplastic pain as diffuse, widespread, and deeply aching.
You know, the source material contains a quote that I think should be printed on the wall of every clinic in the world.
Oh, which one?
It says, myth. The doctors can't find anything wrong, so it must be all in my head. Fact. Medical investigations often do not reveal objective findings related to chronic pain.
It's so true. The texts explicitly state there's a really poor correlation between standard MRI findings and the severity of chronic pain.
I really want to understand the physical mechanism here, though.
Yeah.
How does the nervous system software just corrupt itself?
The literature points to a phenomenon called central sensitization. Sometimes it's referred to as wind-up pain.
Wind-up pain, okay.
Yeah, so we need to look at the microscopic chemical level of the spinal cord and brain. When nociceptive signals, those initial acute pain warnings, are relentless and prolonged, they trigger a whole cascade of neurochemical changes.
And the primary culprit is something called the NMDA receptor.
Exactly, the NMDA receptor, which is located on the neurons in the central nervous system.
Can you break down the biology of that receptor?
Yeah.
Like, how does it physically change a person's reality?
Well, under normal, healthy conditions, the NMDA receptor is actually physically blocked by a magnesium ion.
Okay.
Think of the magnesium as a heavy bouncer standing in the doorway of a nightclub, basically keeping the sensory signals muted.
I love that visual.
Right. But when there is a massive, sustained influx of pain signals, the surrounding neurons release large amounts of neurotransmitters like glutamate and a neuropeptide called substance P.
Substance P, okay.
Yes, and this chemical flood essentially kicks the magnesium bouncer right out of the doorway.
Wow, so with the bouncer gone, the doors are just wide open.
Wide open, massive amounts of calcium flood into the neuron, and this calcium influx fundamentally lowers the threshold of the neuron.
Making it hyperexcitable.
Completely hyperexcitable. The nervous system has chemically amplified its own sensitivity, so a mild sensory input that would normally just be ignored is now processed as a high alert pain signal.
I kind of think of it like the predictive text algorithm on your smartphone.
How so?
Well, if you type a specific phrase often enough, your phone learns it and starts aggressively autofilling that phrase before you even finish the first word.
Oh yeah, that's incredibly accurate.
Right. So in central sensitization, the nervous system has experienced so much trauma that it aggressively autofills the sensation of pain every time the body experiences even a minor stimulus.
That is exactly what happens, and the biology gets even stranger, moving beyond chemical changes into actual structural reorganization within the spinal cord.
Wait, structural changes?
Yeah.
Like physically changing shape?
Yes. We all have different types of sensory nerve fibers. Beta fibers, for instance, are large, myelinated nerves that transmit non-painful sensations.
Like the light touch of a feather, gentle pressure, or vibration.
Exactly. These fibers normally connect to specific non-pain-related areas of the spinal cord. However, in a state of chronic, centralized pain, these beta fibers actually sprout new dendrites.
Physical terminals.
Yeah, new physical terminals that cross over and wire themselves into the superficial laminae of the dorsal horn.
Wait, let me make sure I'm hearing this right. The laminae of the dorsal horn is the area of the spinal cord exclusively reserved for transmitting intense pain signals, right?
That's right.
So you were saying the nerve that tells my brain I am wearing a soft cotton shirt physically grows new roots and plugs itself into the alarm system that says I am being stabbed.
That is the exact mechanism. This physical cross-wiring explains the terrifying symptom you mentioned at the very beginning of the deep dive, allodynia.
The bedsheet's feeling like a blowtorch.
Exactly. It is a measurable physical rewiring of the neural circuitry. But because this sprouting is microscopic, occurring at the cellular level, it will never, ever show up on a standard structural MRI.
This biology so profoundly validates conditions that the medical establishment has historically just sneered at.
Completely. The text specifically named fibromyalgia, irritable bowel syndrome, nonspecific back pain, and tension-type headaches as classic nosoplastic conditions.
And for decades, millions of people were told they were just stressed, anxious, or frankly making it up entirely because their joints looked pristine on an X-ray.
It's tragic.
It's crucial for anyone listening to internalize this. All pain is real and all pain is constructed in the brain.
And failing to recognize the invisible biology of nosoplastic pain leads directly to disastrous clinical decisions.
Because they treat it like nociceptive pain.
Right. Because the central nervous system itself is hyperexcitable, subjecting these patients to structural procedural interventions almost always backfires.
The research is highly explicit about that. Localized procedures like joint injections, nerve blocks, or exploratory surgeries are associated with significantly poorer outcomes for individuals with nosoplastic pain.
Much poorer compared to those with purely nociceptive or neuropathic issues.
It makes complete logical sense, though. If the problem is a system-wide predictive text error in the spinal cord and brain, cutting into a localized piece of tissue in the knee is not only useless, it adds severe acute surgical trauma to a nervous system that is already screaming.
It's literally throwing gasoline on a hypersensitized fire.
So if the data clearly shows that cutting into a nosoplastic pain patient makes them worse, why on earth is a surgical consult or an injection the default next step for a general practitioner?
We have arrived at the silo effect. Modern healthcare is highly fragmented. It's divided into incredibly narrow specialized disciplines.
So a patient with complex, widespread chronic pain is just bounced between neurology, orthopedics, rheumatology, and primary care.
And each specialist exists inside their own silo. They're evaluating the patient exclusively through the narrow lens of their specific training.
I'll give you a real-world analogy for this. If your home's entire electrical grid is surging randomly, blowing fuses in the kitchen, the bedroom, and the garage, you need a master electrician to look at the main breaker panel.
Right.
The silo effect is the equivalent of calling a toaster repairman who takes your toaster apart, says the coils look fine, charges you a massive fee, and then sends you to a refrigerator repairman.
That is painfully accurate. The European consensus papers in our sources reveal the sheer scale of this systemic failure. Pain medicine simply does not exist as a standalone core specialty in many countries' primary medical education.
That's wild. The text mentioned the United Kingdom as an example, right?
Yeah. Yes. Take the UK. The median time spent teaching an undergraduate medical student about pain management is 13 hours.
13 hours. Out of a medical degree that takes years to complete, I spend more than 13 hours researching a new television before I buy it.
It's absurd. And in some institutions, it is as little as 6 hours, taught in a fragmented, piecemeal fashion.
So general practitioners are thrust into the workforce woefully unequipped to manage the transition from acute to chronic pain.
Exactly. Because they lack the tools, they default to referring the patient out to a specialist silo, hoping the specialist has the answer.
Let's look closely at how suffocatingly narrow those specialist silos actually are. The guidelines provided in the sources for lumbar spine surgery highlight this perfectly.
They really do. To even be considered a candidate for a decompression surgery, a patient must present with incredibly precise symptoms.
The floor chart required something like neurogenic claudication, radiating leg pain that worsens dramatically when standing, but is miraculously and immediately relieved the second the patient sits down.
Yes, and that specific symptom must perfectly correlate with a specific MRI finding, like moderate to severe central spinal stenosis.
So the surgical pathway is a rigid algorithm.
Incredibly rigid. If a patient's clinical presentation deviates from that flowchart, perhaps their pain doesn't stop immediately when they sit, or their MRI only shows mild stenosis despite their severe agony.
The surgeon looks at the flowchart, looks at the patient, and declares, there is nothing more we can do.
And that phrase is a psychological weapon.
It really is.
Oh,
When a patient who has been waiting 6 months for this consultation hears, there is nothing more we can do, it sounds like a terminal diagnosis for their quality of life.
they hear, your suffering is permanent and medicine has forsaken you.
We have to aggressively reframe what that phrase actually means in the context of hyperspecialization.
We do. When a specialist says there is nothing more we can do, it does not reflect the end of your biological potential to heal. It simply means you have reached the absolute border of that specific specialist's toolset. The orthopedic surgeon is really just saying, I do not have a structural target to cut with my scalpel.
And the interventional radiologist is saying, I do not have an inflamed joint capsule to inject with steroids.
Exactly. It is a limitation of their specific silo, not a limitation of your biology.
The text actually mentions patient-related barriers, noting how patients feel utterly dismissed by doctors who fixate on treating a visible, underlying disease rather than managing the objective experience of pain.
Yes. A doctor views success as an MRI that looks cleaner after surgery. The patient views success as being able to pick up their toddler without collapsing in agony.
It's a complete disconnect. And the persistence of these silos wasn't just an accident of medical training, it was reinforced by decades of bureaucratic neglect.
The literature points out a staggering historical fact. For a very long time, chronic pain lacked a specific World Health Organization ICD-10 diagnostic code.
The International Classification of Diseases.
Yeah.
But why does a billing code dictate patient care?
Because in modern healthcare, if you do not have a code, your disease does not officially exist.
Wow.
Without an ICD-10 code recognizing chronic pain as a primary disease in its own right, doctors had to bill under vague symptoms like backache or headache.
So because the specific disease of chronic pain didn't formally exist on paper, health authorities and insurance companies didn't allocate funding for it.
Exactly. Politicians didn't formulate public health policies around it. It starved the field of research money.
And prevented the establishment of specialized interdisciplinary pain clinics, which just forced patients back into the inappropriate surgical and neurological silos.
Right. It wasn't until the transition to the ICD-11 that chronic primary pain was finally documented as its own legitimate entity.
So we have a system where a patient like Mark is invalidated by normal scans, bounced between silos, subjected to procedures that might physically worsen his nelsoplastic pain, and historically ignored by insurance bureaucracy.
The psychological devastation of that journey alone is immense.
Oh, absolutely. But the relationship between mental health and chronic pain isn't just a byproduct of a frustrating medical system. It is a biological, deeply bidirectional bridge.
Yes, and we are turning now to that massive umbrella review covering over 17 million individuals.
Data mapping the prevalence of chronic pain within psychiatric populations is just staggering.
Let's look at the comorbidity rates. Up to 96% of individuals diagnosed with post-traumatic stress disorder experience chronic pain.
96%.
For those with attention deficit hyperactivity disorder, it sits around 66%. In populations with major depressive disorder, it ranges between 53 and 65%. And for schizophrenia, it is roughly 30%.
These figures violently eclipse the baseline general population rate, which hovers around 20%.
They really do.
I mean, 96% in PTSD. That is essentially a one-to-one correlation. You cannot look at that number and pretend the brain and the body are separate entities.
No, you can't.
But a skeptic might say, well, of course they are depressed. They are in terrible pain all day. The sources, however, use something called Mendelian randomization studies to prove this isn't just a reaction, it's a two-way biological street.
Right. Mendelian randomization is a fascinating epidemiological tool. Essentially, it is nature's randomized trial.
Okay, how does it work?
Researchers use measured variation in genes of known function to examine the causal effect of a modifying exposure on disease.
In simpler terms.
In simpler terms, they look at people who are genetically predisposed to major depressive disorder, meaning they carry gene variants linked to depression independent of their life circumstances.
Got it.
The studies show that having these specific genetic variants for depression significantly increases the risk of developing chronic regional pain later in life.
So it completely removes the environment from the equation. It proves that the biological state of depression itself causes pain.
Yes. And conversely, carrying genetic variants that predispose someone to multi-site pain inherently increases their risk of developing depression. They are physically constructing each other.
And the shared neurobiology explains why. Emotional distress and physical nociception share identical neural real estate in the brain.
Predominantly within the anterior cingulate cortex and the amygdala, which are the brain's emotional processing and fear centers.
Right, so when you experience chronic pain, your body perceives it as a state of severe, unending threat, which keeps the sympathetic nervous system, the fight-or-flight response, permanently activated.
So your body is constantly marinating in stress hormones like cortisol and adrenaline.
Precisely. And while the stress hormones surge, the texts note a concurrent, devastating drop in crucial neurotransmitters like serotonin, norepinephrine, and endogenous endorphins.
And these aren't just feel-good mood chemicals, right? They are the fundamental components of the brain's descending pain modulatory system.
I really want to highlight that concept, the descending modulatory system, because most people think pain signals only travel up from the body to the brain.
Right, but the brain has its own active downward-facing circuitry. When a pain signal travels up the spinal cord, a healthy brain sends serotonin and norepinephrine down the spinal cord to actively inhibit or block that incoming pain signal.
It's literally a biological braking system.
Exactly. When depression or severe chronic stress depletes your serotonin and norepinephrine, you literally lose the biological brakes on your pain signals.
The pain threshold plummets.
Yes. A minor ache is suddenly registered as severe agony, which increases your stress, which further depletes your serotonin. It is a closed-loop neurochemical nightmare.
The umbrella review details specific behavioral risk factors that accelerate this loop, too. Catastrophic thinking is a major one.
That deeply held belief that the pain will never end, that it is a sign of an undetected terminal illness, and that it will inevitably destroy your life.
And fear avoidance behavior, where you stop moving entirely, which leads to the muscle atrophy we discussed earlier.
Plus severe insomnia, which prevents the brain from clearing metabolic waste, heightening neural inflammation.
But the research also highlights protective factors. Employment, strong social-emotional support, and active adaptive coping strategies physically buffer the central nervous system against chronification.
This brings us to a highly counterintuitive paradox regarding how different mental health conditions modulate pain.
Right, this part is fascinating.
While depression, anxiety, and PTSD lower the pain threshold and amplify sensitivity, the data reveals that schizophrenia often manifests the exact opposite biological response.
Individuals with schizophrenia frequently demonstrate significantly elevated pain thresholds and increased pain tolerance.
Yes.
But wait, hold on. If emotional stress and distress make pain worse, and schizophrenia is arguably one of the most profoundly distressing mental health conditions a human being can experience, shouldn't their pain sensitivity be off the charts? Why does the biology suddenly reverse itself?
It comes down to fundamentally altered neurochemistry, specifically regarding the dopamine hypothesis of schizophrenia. The disorder involves significant dysregulation of dopamine receptors and altered endogenous opioid activity in the brain.
And how does that affect pain?
This neurochemical environment seems to alter sensory gating. That's the brain's ability to filter out incoming stimuli. So that nociceptive signals from the body are generated, they travel up the spine, but the altered dopamine pathways in the brain essentially filter the pain out before it reaches conscious, distressing awareness.
Which sounds like a bizarre superpower on the surface. But the sources emphasize how incredibly lethal this actually is.
It is extremely lethal because pain is an essential biological alarm. A blunted alarm system means catastrophic medical events. A ruptured appendix, a silent myocardial infarction, or an aggressive metastasizing tumor can go entirely unnoticed by the patient.
Until they're in irreversible septic shock or end-stage organ failure.
Exactly. The lack of pain reporting catastrophically delays life-saving interventions.
And even if a patient with a severe psychiatric disorder does recognize their pain and reports it, they run headfirst into a systemic bias outlined in the research. Diagnostic overshadowing.
Diagnostic overshadowing is a pervasive, dangerous cognitive bias in healthcare. It occurs when a physician erroneously attributes a patient's physical symptoms entirely to their pre-existing psychiatric illness.
So a patient with known bipolar disorder or schizophrenia enters an emergency room complaining of excruciating abdominal pain.
Right. And instead of running a CT scan to check for a bowel obstruction, the attending physician assumes it is a somatic manifestation of their psychiatric condition or a delusion.
And requests a psychiatric consult instead. They dismiss a biological emergency because of a psychiatric label.
It's the ultimate failure of the silo effect. The doctor sees the mental health silo and refuses to look at the physical biology.
So the picture we've painted is honestly pretty bleak. Patients trapped in silos, told their pain doesn't exist, subjected to surgeries that worsen their nonsplastic neurochemistry, and caught in a bidirectional neurochemical loop with depression.
It's a dark place to be.
How do we break the loop? If specialized silos fail, what does the bird's eye view of interdisciplinary care actually look like?
Well, the fundamental first step of interdisciplinary care requires a massive psychological shift from both the medical establishment and the patient.
Okay, what kind of shift?
You must abandon the acute pain model. The goal of treatment must explicitly pivot away from complete elimination of pain. That expectation only breeds failure and deeper depression.
So what is the new goal?
The new explicit goal must become quality of life optimization and functional restoration. You transition from trying to fix a broken machine to managing a complex chronic ecosystem.
And to manage that ecosystem, the clinical guidelines universally mandate a multimodal approach. You cannot attack a multidimensional disease with a single weapon.
Exactly. You must combine non-pharmacological therapies like targeted physical movement, sleep hygiene, and cognitive therapies with a highly selective, cautious pharmacological strategy.
The pharmacological guidelines are very specific about stepping away from traditional painkillers for nociplastic pain. Because the issue is a hyperexcitable central nervous system, standard anti-inflammatories like ibuprofen do very little.
Right. Instead, the guidelines recommend medications that target the neurochemistry of the brain and spinal cord. We mentioned SNRIs earlier, serotonin norepinephrine reuptake inhibitors.
Which were originally developed as antidepressants, right?
Yes, but they are highly effective for chronic pain because they artificially flood the descending modulatory pathways with serotonin and norepinephrine.
Effectively reinstalling those biological brakes we lost during the depressive spiral.
Exactly. The sources also mention gabapentinoids.
Yes, medications like gabapentin or pregabalin. They operate by binding to specific calcium channels on the hyperexcitable neurons.
Remember how the NMDA receptor was flooded with calcium?
The bouncer was kicked out.
Right. Gabapentinoids restrict that calcium flow, essentially dampening the excessive electrical firing of the damaged nervous system.
And noticeably absent from the primary recommendations are opioids.
Because opioids are a disaster for nociplastic pain, the guidelines relegate them to an absolute last resort, tightly monitored.
Because not only do they fail to improve long-term function, they carry the risk of opioid-induced hyperalgesia, where the drug actually makes the nervous system more sensitive to pain over time.
Exactly. What I love most about the multimodal approach in the sources is how they quantify it. They provide the math of pain relief.
The math provides a realistic, manageable framework for patients. A doctor explains, this SNRI medication might only reduce your overall pain by 20%.
Which sounds small.
But if we combine it with specialized physical therapy, which reduces it by another 20%, and cognitive behavioral therapy, which reduces the distress by 10%, cumulatively, we're looking at a 50% overall reduction in your daily pain.
And a 50% reduction isn't a total cure, but functionally, it is a new lease on life.
It is the difference between being entirely bedbound and being able to walk your dog or make dinner for your family. It shifts the patient from despair to functional capability.
This ties perfectly into the crucial distinction the texts make between active and passive interventions.
So passive interventions are therapies done to the patient. A surgeon cuts into your spine, an anesthesiologist injects a steroid into your joint, a massage therapist manipulates your muscles, you swallow a pill.
Right. While passive interventions can offer necessary short-term relief, the evidence emphatically shows they are insufficient for treating complex nociplastic pain.
Because they don't force the corrupted central nervous system to adapt or change its programming.
Precisely. To rewrite the corrupted software, you need active interventions. These therapies leverage the brain's incredible power of neuroplasticity.
Which is its biological ability to forge new neural pathways and prune away maladaptive ones.
Exactly. Active interventions require the patient's conscious, physical, and cognitive effort. The guidelines highly recommend mindful movement practices like yoga, tai chi, or qigong.
And these are incredibly effective because they combine gentle, progressive physical loading, which rebuilds the atrophied muscles, with deep parasympathetic breathing that actively calms the hypervigilant nervous system.
Water-based activities like aquatic therapy are also great. They allow patients to build strength in a buoyant environment that significantly reduces mechanical joint load, bypassing the nociceptive triggers entirely.
It's literally retraining the brain. You are teaching the nervous system that movement does not equal tissue damage. You are rewriting the predictive text algorithm.
But the texts are brutally honest about the timeline. This is not a quick fix.
No. Rewriting complex neural maps takes immense consistency, usually requiring a slow, steady process over a 6 to 12-month period.
To support patients through this arduous timeline, the sources introduce a fascinating systemic concept called universal precautions.
We typically associate universal precautions with infectious disease control, right? Wearing gloves, using sterile needles, treating every single patient's bodily fluids as potentially infectious.
Right, to protect the staff, without profiling or judging the patient's background. The guidelines suggest applying this exact philosophy to chronic pain management.
How does that translate to a pain clinic?
It means removing the physician's subjective bias from the equation. Instead of a doctor looking at a patient and deciding, based on their own prejudices, who looks like they might need a psychiatric referral, or who looks like they might be at risk for opioid misuse.
The clinic implements a standardized, comprehensive assessment for every single patient who walks through the door.
Every patient gets the biological assessment, the psychological screening, and the risk evaluation. It completely removes the stigma.
If everyone gets screened for depression, the patient doesn't feel singled out or accused of making it up when the doctor suggests therapy.
It ensures that no psychiatric comorbidity is missed due to diagnostic overshadowing, and no patient is prescribed high-risk medications without a rigorous, standardized safety net in place.
And a cornerstone of that psychological safety net, heavily emphasized in the clinical psychology texts, is a modality called acceptance and commitment therapy, or ACT.
ACT is a massive paradigm shift from traditional pain psychology. It doesn't try to teach you to ignore the pain or pretend it doesn't hurt.
The fundamental premise of ACT is recognizing the profound difference between pain and suffering.
The physical sensation of pain is a biological reality. It hurts. But the suffering is generated by the individual's desperate, exhaustive psychological struggle against the pain.
When a patient is consumed by the need to eliminate the pain before they can resume their life, when they wake up and their first thought is a panicked, I have to stop this feeling, they're essentially fighting a war against their own nervous system.
And that cognitive struggle maintains a state of high psychological stress, which, as we established earlier, floods the body with cortisol, depletes serotonin, and physically amplifies the pain signals.
The struggle feeds the alarm.
Exactly. ACT teaches patients to drop the rope. It teaches psychological flexibility. Acceptance does not mean passive resignation or giving up hope.
It means acknowledging the reality of the physical sensation in the present moment without panic.
And the commitment part of ACT means committing to engaging in deeply valued life activities despite the presence of pain.
You shift your internal monologue from, I cannot go to my daughter's graduation because my back hurts, to my back is going to hurt whether I stay in bed or go to the graduation.
Right. I value being a father, so I am going to the graduation, and I am bringing the pain along with me in the passenger seat.
The neurobiological irony of ACT is profound. By intentionally ceasing the cognitive struggle against the pain, the patient de-escalates their sympathetic nervous system.
The stress hormones drop. The descending modulatory pathways can function more effectively. By accepting the pain, the nervous system naturally downregulates, which frequently leads to a measurable physical reduction in the intensity of the pain itself.
It is a remarkable feedback loop. Let's take a breath and synthesize this massive journey we have taken the listener on today.
We covered a lot of ground.
We started by dismantling the triage mandate, revealing that treating chronic pain like an acute fire only leads to muscle atrophy and despair.
We explored the microscopic landscape of nociplastic pain, detailing how the NMDA receptor and structural cross-wiring create a hyperexcitable nervous system that standard MRIs are entirely blind to.
We examine the systemic failures of modern medicine, how the hyper-specialized silo effect traps patients in rigid surgical flowcharts, and how the historical lack of an ICD-10 billing code starved the field of holistic care.
We unpacked the dense bidirectional biology connecting major depressive disorder and chronic pain, proving that the mind and body are an inseparable neurochemical ecosystem.
And most importantly, we mapped the escape route from the silo. Escaping the dead end requires demanding a bird's-eye view, shifting the goal from a total cure to quality of life optimization.
It means utilizing the math of pain relief, combining targeted pharmacology with active neuroplastic therapies to slowly, steadily rewrite the corrupted software of the brain over months of dedicated effort.
It is the ultimate transition from being a passive recipient of fragmented medical procedures to becoming the active architect of your own neurological rehabilitation.
Exactly.
Which leaves us with a final provocative thought to mull over. If we fully accept the neuroscience that all pain is fundamentally constructed and modulated by the brain, and if we recognize that the brain possesses this astounding lifelong neuroplastic ability to reorganize its own physical architecture based on our movements, our environments, and even our psychological acceptance.
Does that mean the ultimate frontier of pain medicine isn't going to be a sharper surgical scalpel or a more potent synthetic chemical?
Is the future of chronic pain relief actually about learning how to consciously hack, edit, and rewrite our own neural software?
That is precisely the frontier we are standing on. The locus of power is slowly shifting from the surgeon's flowchart back to the incredible adaptability of the patient's own central nervous system.
So keep questioning the rigid systems. Keep exploring active, multimodal therapies. And remember, the next time you or someone you love are sitting in a specialist office and they look at a perfectly clear structural scan and say, "There is nothing more we can do," just smile, stand up, and realize it doesn't mean your biological reality is a dead end.
It just means it's time to find a much better map.
Thanks for taking the deep dive with us.